You guys, thank you so much for coming to our symposium. We've had amazing speakers. It has been a great day, and I know tonight is going to be phenomenal as well. So as Dr. Casita said, my name is Michele Kilmer. I'm an assistant professor at the Eleanor Mann School of Nursing. I'm also a certified pediatric nurse practitioner, and I'm the director of the university's Access for Autism program. So before I begin, I must introduce some of the very important people who work for Access for Autism or who collaborate with us and make this program work so well. And the very first person I want to introduce is Danielle Randolph. Yeah, stand up. Danielle Randolph is a registered nurse. She's the program manager, and she's the reason that the program is successful. She took my idea and she made it her own, and she is the powerhouse behind it. It would not be what it is without Danielle. I also would like to introduce Dr. Minju Hong, who is our statistician. She ensures that our studies are rigorous and have good methodologies and that the results are accurate and reliable. And along that line, Dr. Lauren Quetch, who is with the Fulbright Department of Psychology. My collaboration with her is one of the biggest blessings. She has been such a great mentor to me, helping me to take my ideas and make them smaller so that they're realistic, and then help them to come to life. I've learned so much from Dr. Quetch, and she's truly amazing. Ben Pollock couldn't be here today, but he did our website, and I wanted to acknowledge that for him. And then the soon-to-be Dr. Emily Shaw, who is also with the psychology department. She worked with us last year. She and I and Dr. Hong and Dr. Quetch, we published together, we presented together, and Emily was just a vital force last year to help the program grow. And with that, soon to be Dr. Victor Akapu, who is the graduate assistant, and right there he is. He's working with us this year as well. He has entered data on almost 5,000 interactions. He is wonderful. He's helping me write publications and present and analyze all this amazing data we're about to go through. Tara Hawley and Emily Richardson. I know Tara is here. She is a clinical instructor. There she is with Eleanor Mann School of Nursing. And she assists me with animal-assisted therapy research. And then none of this would be possible without the undergraduate honor students. And I think only two could be here right now, but we have Allie and Caroline. And I want those girls to stand up because they have done so much with Griffin to get him here. I also want to thank all my MSIN colleagues and the speech and occupational therapy departments because they let Griffin be Griffin. And they have been so wonderful in this work, along with my amazing family who see me on the computer all the time and support me in what I do. They are 100% involved. And then my family who's right with them. We're not friends, we're family. And here they are supporting me today. I like to thank Dr. Casita for explaining to me and helping me understand a research trajectory and how to accomplish what I want to accomplish. And then Dr. Shirley Taylor from the FAR Fund, who helps support our work as a clinic. I believe she is here right there. Dr. Taylor forever has my heart. She is so encouraging. So if you want to talk to one of the most encouraging people you'll ever meet, Dr. Taylor. And lastly, Griffin, sit. This is Griffin, yeah. This is Griffin. He is a 2-year-old male black lab, and he is who we're going to be talking about today. So the Access for Autism program, just quickly, as you can see, is an interdisciplinary program in which we offer diagnostic evaluations, we help provide care management, but we also offer animal-assisted therapy. And these sessions include sensory integration, some elements from ABA and cognitive behavioral therapy. I'm so excited to add EMDR this coming April. Thank you. I'm very excited about that. And we always include parenting strategies. And you can see we have our website information on this as well. And you may be wondering, why is a nurse working in animal-assisted therapy doing EMDR and all these weird things? And for this, I want to talk to those little people over there in the red. It's because nurses are scientists, and we can do this, right? Florence Nightingale, the mother of modern nursing, actually wrote about the importance of including animals in the plan of care and healing for patients, because she noticed in the Crimean War that patients who interacted with birds had better mental health and better health outcomes. So she wrote in her journal that nurses needed to study the human-animal interaction in the environment of healing that it has. So we're just fulfilling what she wrote all those years ago as nurses. So my trajectory and what I want to do with this research is work with clinicians and work with caregivers in our area and help them identify autism early. Hey, buddy, sit. Help them identify autism early, because we know because of neurodevelopmental developmental cascades and neuroplasticity that the earlier we identify autism, the earlier we intervene, the better the outcomes will be. So our aim is to do that with the clinicians and caregivers, but then the intervention, which is what we're going to talk about now. Just to give you a little understanding of the caregivers that we have here in Northwest Arkansas, because I think that's very important. They face so many social determinants of health that are specific to this area that we have to take this into account so that we can design interventions that will be successful in this group. They have higher anxiety, stress, and depression levels. They have higher ACE levels than the national average. You may have to go. And we found that there was a 3-year delay in the time in which a caregiver was told to seek an evaluation and the time in which they did. And the main reason was they just mentally weren't ready to face that yet. So whenever we have any intervention with caregivers here, we have to have that in account. What will work for them with what they're facing? So I know that the use of service dogs in autism therapy is going up. And as Ms. Henry explained very well in the preceding talk, therapy dogs and service dogs are very different, and service dogs are trained to help one person, but they can be quite expensive. And many families here can't afford one, and they cannot afford to keep one in their home. So my thought was, what would happen? Could we train a dog to be a therapy dog and serve a lot of kids, but train them in those tasks? And will we get the same effect as a dog? I'm going to trust you. Good boy. Place. Will we get the same effect if we don't have a service dog paired to this child? Because what we want to do is to create lasting changes in the brain through the interventions that we have. So what is animal-assisted therapy? Animal-assisted therapy involves the strategic use of using animals to accomplish therapy goals. It is not simply interaction. It is not simply petting. Dogs and other animals, but I'm going to only speak about canines, can do so much more. And we know that animal-assisted therapy has improved communication, socialization, social emotional competence, attention, and self-regulation in kids with autism. So we know the basis works, but can we get this guy to help many kids instead of one? So the number one question I'm asked is, what does Griffin do? Exactly what does he do? And it's a great question, because if you Google animal-assisted therapy, you're not going to find any interventions at all. You will not find any protocols, any recommendations to obtain the outcome that you want, because they're not existing yet. And so Griffin is trained as a therapy dog. He's a certified therapy dog. He has passed his AKC Good Citizen test. And those therapy dogs are mostly known for comfort measures. They are petted, they provide pressure therapy. Think of when you're in the hospital and you're visiting a child who is getting a shot, for example, and the sweet little therapy dog is sitting by them. And before I got Griffin, I really did want to meet as many therapy dogs as I could. And what I saw was I really wanted my dog to do a little bit more than that. And there's nothing wrong with therapy dogs, but I work with kids who need to interact. I don't work with kids who will typically want to pet a dog. And so I wanted a dog with drive, and that's what you're hearing right now. Griffin's trained to interact. Good job, buddy. He, for this reason, knows 54 cues because this is how we trained him to interact with all the kids. He knows 10 ASL signs for the kids who are nonverbal. And so all of these things, we worked for a year helping him learn how to do these with kids. And that's why my honor students are wonderful because they work with him all the time. But Griffin is also a service-trained therapy dog, a service dog. He, as Miss Henry was saying, a service dog is trained to serve a person with a disability. So yes, in that way, no. But what I wanted was for Griffin to be trained just as a service dog would be for one person. And so you have to have 3 tasks to be a service dog. We'll wear a little extra. Griffin has 10 tasks that he can do as a service dog in the clinic. And this was one of the vital parts of our research. Could we train him to do these tasks for other kids, not just for one? So what we did was we actually trained him using me. And he picked it up very quickly. Griffin is smart. But then it took me about 9 months to get him to understand those things I want you to do, I want you to do for other people. And then once he understood that, he had it. He would be able to perform those tasks in clinic with whoever I told him, which is because we have a lot of trust. He knows I'm not going to put him in a bad situation. And when I tell him to go hug someone, that person is going to hug him and he's going to be okay. So the AAT program are studies that last from 8 to 12 weeks. Now, Dr. Quetch and I did one for 6 months. I'll never do that again. But we did our first one for 6 months. But now 8 to 12 weeks is about a good time that we figured out. And they last for 30 minutes to 45 minutes each session. Down, down. He's a dog, right? You can't really make him do, no, you can't, down. So, free play is a very important part of what we do. Do not underestimate the power of play therapy with these kids. So for 5 to 10 minutes at the very beginning, Mackenzie, go ahead and take him. For 5 to 10 minutes at the very beginning, the kids play with Griffin, and he loves to interact. Griffin has drive. He has a temperament to go. So the kids earn the privilege to free play with him before we start our therapy sessions. And then we have sensory integration activities. Yeah, you're in trouble. You got to go with her. All right, go. Go. After we do our free play, we do sensory integration therapy. And then we go into what I call table time. And during this time is when we do our ABA. I'm not an ABA therapist, but I do some of the techniques I've been taught. And cognitive behavioral therapy, some of those techniques, because I don't find all of them work well with autistic kids. And then this is when we're also going to do EMDR. So this is an important part that I have to emphasize. I only have the ability to record the sessions that are done during the table time. Griffin plays with the kids outside of the clinic room. So all the data that we've recorded has been when I'm sitting down at the table with the children and Griffin is sitting beside them, and he is trained to sit there and not whine and be still and be there for them when we're working. And so remember that, because it comes into play here in a minute when we look at the data. And then we always try to end our sessions with free play again. I want the kids to leave happy, and I want them to leave excited to come back to see Griffin. But on his own, in addition to all those things that Griffin was taught, he has picked up some habits on his own. He has taught himself 5 ways to approach a child. He will get on his belly and crawl to a child if they're afraid of him, or he'll just walk right up to them. He'll bring a ball and drop it at their feet because he wants to play fetch. Or he'll bring a toy. Sometimes it's a tug-of-war toy. Or with the little ones, he'll bring like one of his sweet stuffed animal toys. And then he will roll a ball with his nose. And we actually put a word with that so that I could cue him to do it. Because it's amazing to watch children who are a little afraid of him at first warm up to him so quickly when he lays on his belly and rolls a ball to them. And then they roll it back, and then he rolls it back, and before long they're playing fetch. So he taught himself to do all those things. He also taught himself to sense anxiety. And it's one thing I wanted his trainer to do. I wanted Griffin to be able to sense the onset of emotional dysregulation. And he does. He knows how to sense anxiety. So during the table time, he will lay his head on the children's feet. And when he starts to sense that they're anxious, he'll start nudging me. And then he'll nudge them to try to promote dual awareness. He doesn't know that's what he's doing, but that's what we want him to do, to try to bring them a little out of their anxiety. And then he will sit beside the child and let them pet his ears because they're very soft. And then he'll lay his head or his entire body across their lap to try to release that oxytocin level and let them calm down. And if none of that works, I have learned when he starts to pace, we need to stop, because the times I haven't, the children have become so emotionally dysregulated that they lose control. Not because of Griffin, but because of what we're trying to work on is so distressing to them. So when he starts to pace, that's my visual cue of, hey, Griffin thinks we need to take a break. Let's go kick the ball. And then we come back and we finish what we're doing. The other thing, and this is where Dr. Hong comes in so importantly, is that many systematic reviews have shown that the study of animal-assisted therapy, especially with canines, have used weak research methodology. So for that reason, we use 4 different instruments to measure prosocial behavior and emotional regulation. So what that means is prosocial behavior are helping behaviors: empathy, socialization, communication, helping if someone's hurt, caring behaviors. And then emotional regulation is just that, our ability to regulate our emotions. And it doesn't just mean a meltdown, because I know we think of meltdowns first, but we can be too happy or too sad or not be able to control how we feel. So Griffin, actually, we look at 4 different methods of emotional regulation assessments to see how Griffin can interact with these kids to improve their behavior. 2 of the assessments we use during the session, and then 2 of the assessments are used outside of the session. Because I don't only want to know, hey, does this work in the session? I want to know, is the effect lasting outside of the session? Because it's not quite good enough if they're great for me for 30 minutes a week. What I want to see is it makes a difference to these families outside of the sessions. So I wanted to start with this case study before I presented the aggregate data on all that we've been doing the last 18 months. And this case study is of a 7-year-old verbal speaking in complete sentences male with documented deficits in adaptive functioning, presence of maladaptive behaviors, clinically significant deficiencies in reciprocal social behavior that so severely interfered with his social interaction that he was pulled from a typical classroom and was in an alternative learning environment simply because he could not control himself. He had received speech language therapy, occupational therapy, and weekly counseling sessions for a year prior to coming to us. His ADOS score, which is one of the instruments we use when we're evaluating children specifically for autism, when we look at the comparison score on a scale of 1 to 10, his was 6. So that kind of indicates he was about a moderate severity of autism. And Griffin was 2 years old when we met this boy. And Griffin had completed therapy dog training and was in the process of learning how to do the deep pressure therapy, but he could do most of the other tasks. We ended up evaluating 588 interactions between this boy and Griffin alone. Again, only during the seated time when Griffin was supposed to be still and not interacting, because I can't record it outside of the session. And what we found were 99% of the interactions were very positive. The voice communication and affection domains were improved, and they were the most prevalent behaviors that we saw. And most importantly, you see that Griffin was the target of the verbal interaction. And he wasn't supposed to be. I was the one talking to the kid. I was the one doing the work. That was table time. But this just showed me, no, the child wants to include Griffin in the therapy. He wants Griffin to be just as much a part of this as what we did outside. So then, when we look at the apart from the sessions, we see that the child experienced improvement in prosocial behavior and emotional regulation in all the domains except for conduct problems, which alerts me to the fact that I need to do more interventions in my sessions that deal with conduct problems, mostly impulsivity. That's what the conduct problem domain usually talks about with the SDQ. And then you can see the PANAS score, and that's a weekly score that looks at positive affect and negative affect. And we see here, you see that little bump in the middle where the positive went up and the negative went up? That was grandma visiting, and he was very fixated that she was leaving. So he did have a difference in those 2 weeks, but that's fine, that's life, right? But we can see a trend. The positive went up and the negative went down. And if you look at weeks 6, 7, and 8, when we were helping him recover, if you will, from his grandmother's visit and the fact that she left, you can see positive was going up, negative was going down, and that's exactly what we wanted to see. So the aggregate data, Griffin and I have completed 4 studies, some 6 months, one was 6 months, and then the rest were 8 to 12 weeks. And we just finished our data analysis, because you can imagine if one child has 588 interactions, you have 13 kids, it takes a while. But we put all of this information together in looking at verbal ability. So right now what we're trying to look at with our studies is, does Griffin interact differently with kids with different intellectual ability, verbal ability, ethnic groups, ages, genders, and symptomology of autism? So right now we have data for the verbal versus nonverbal group. And I want to clarify, nonverbal group is a term that we use for the ADOS that includes children who use vocalization only, children who are pre-verbal, which means they use about 10 or so words per the ADOS, and then the phrase speakers who use 2 to 3 words and phrases to communicate. Once they begin to speak in complete sentences, we change them to the verbal group. So you can see here, we had 2,007 interactions in the verbal group of 9 kids, compared to 64 interactions in the nonverbal group. So when we look at the blue, which is the verbal kids, you see the communication and the comfort domains were the most prevalent for them. And when you look at the green, you see the affection domain was the most prevalent for the nonverbal group. They love petting him. They want to pet his face, they want to pet his ears, they want to pet his head. Now, I have to show the withdrawal in the green group where it says 31% withdrawal. That was one kid who loved the word no. And we had to code it because he said it. But if you take that one kid out, you don't have withdrawal from the other 3. But we left him in because Dr. Hong is a great research analyst, and that's what you're supposed to do. But it looks like withdrawal was occurring more often than it really was. But the difference in the interaction is statistically significant. So now moving forward, I am trying to find new ways to get these kids that are nonverbal or using phrase speech to interact more. And I've completely rechanged a lot of things that we do in the clinic based on this data. So also the verbal group had 909.5 minutes of interaction compared to 31 minutes of interaction in the nonverbal group. And that again is statistically significant. So that alerts me to the fact that I need to add more activities for the nonverbal group to get them to interact more. And here you see, again, the comfort in communication and affection. So apart from the sessions, the SDQ, so that tells us about the behavior of the child apart from the AAT session. Now, interestingly, none of the families in the nonverbal group consistently completed this assessment, even though they did it right in front of me. So I can't figure out how that happened, but I only have consistent data in the verbal group. So that's another thing I need to, moving forward, figure out with the nonverbal group. Why did that occur that they wouldn't or couldn't or didn't complete these assessments? But you can see here in the first column to the left at the top, the 5 domains of the SDQ. Basically, you have your emotional domain, your peer problems, your contact problems, your prosocial behavior, and your hyperactivity. Prosocial behavior is the only one you want to see go up. Everything else you want to see trend down. But you can tell with the means of all the kids in the verbal group that the conduct problems and the hyperactivity, they improved halfway through, they started going back up. So that informs me again, that matches the case study. I need to look for interventions to do to keep the progress going down. You can see the impact mean, and that's the one I'm very proud of, because the SDQ impact mean measures the impact of the child's behavior on the family's stress and the family's interaction and the family's bonding. And I want to see that number actually go down, because that means they experience less distress. They experience less episodes to where they weren't bonding. So that's a good sign that animal-assisted therapy was working in these families to promote bonding outside of the clinic. When you look at the maladaptive behaviors, you see that the orange is going down, and that's the internalizing domain. And it's consistent, is comprised of the peer problems and the emotional problems. So those domains improved. The one that's trending back up is comprised of the conduct problems and the hyperactivity. And again, we need to fix that moving forward to address those concerns so that we can have better results in those domains. But when we look at the weekly affect scores, you can see exactly what we want to see. There was a decrease in negative affect in these kids and an increase in positive affect for these kids. And if you have a child with special needs, having a decrease in negative affect and an increase in positive affect makes a big difference in your quality of life. So I'm really proud of that score specifically. But I wanted to key in on this, and if you're an occupational therapist, if you're a speech language pathologist, if you're a physical therapist, this is very important. Remember, I only have the ability to record my work in the table time. It does not take any of the free play time, and that's about 15 minutes of a session. I can only record when I'm sitting at the table with the kids. So you would expect, I'm the therapist, you would expect the majority of the communication to be to me, right? But look at how many of the kids involved Griffin. Even kids in the nonverbal group wanted to interact with him during table time. And again, this confirms to me that we can use these canines during the therapeutic process to achieve our outcomes. The kids want Griffin to be involved in their work. In fact, I have had occupational therapists and speech language pathologists call me when I have their kids in my program and say they want to meet their goals because they want to throw a ball farther. They want to run faster. They want to communicate more so they can make him do 54 tricks. So it is showing me that he's a motivating factor because Kids love Griffin. They love him. I've even heard people talk about him today. Oh my word, he's the happiest dog. These are things that kids consistently tell me. Griffin will be so proud of me. Griffin is always happy to see me. Griffin believes in me. More than one child has told me these things, and Griffin is nonverbal, right? He's not saying these things, but he has the most sweet eyes, and he wiggles when he walks, and he wags his tail, and they are right. He is always happy to see them. They can leave for 5 minutes and come back, and he is just as happy to see them as he was 5 minutes before. He provides a sense of security to them that I did not appreciate when I started this 18 months ago. And this has really become a very big part of my work, is to figure out just how important is this dog in what I'm doing. And for that, I have to thank Dr. Grandin for helping me design the Snuffles study. So you might have seen Snuffles with the posters. He is a plush toy dog that looks just like Griffin. And we have 2 groups. One group has Griffin, and the other group has Snuffles. And they are homogeneous, and we make sure the groups look just as much alike as we can. And I do the very same thing for each group. We've completed our first, we've completed our first study, and you can guess anecdotally which group did better than the other, the canine trained in 54 tasks, or the Snuffles. It was Griffin. But we're going to go ahead and do 3 more of these studies this year, because I'm also looking at, well, what if a child's allergic to a dog? Or what if a child is afraid of a dog? Is there some way we can use a toy animal to help the kids attain their therapeutic goals? I'm also very interested in the ethical use of these animals, like Miss Henry was explaining. There's really no regulation. I can work Griffin as hard as I want. So what we're doing here is we evaluate his behavior by coding it in the sessions. We record them, and then later we watch those videos and we record every behavior we see of his. And what we have seen with his affiliative, his social behavior, is Griffin's anyone's dog who wants him. He'll go to anyone. Anybody. It doesn't matter their age, their ethnicity, their verbal ability, their intellectual ability, their autism symptomology. If you're there, he's there. Let's have fun. We've also noted very minimal stress-related behaviors with him. Now, again, he's a highly driven dog. The hardest thing I had to teach him was to sit still. He always wants to be going. It is not for every canine, and I have to make that so clear. There are some canines who would not want to work with me in my clinic, but Griffin is driven and he wants to. And there was only, of all these interactions, 1 occurrence of withdrawal, and that was when he got poked in the eye, and I can't blame him for that. I always keep a crate in the clinic room, and if I feel that he is becoming stressed or the child may be becoming stressed, then I'll tell him to go to his office, and he goes into the crate. I'm always looking out for his safety and the child's safety. So if you're going to introduce canines into your therapy plan, you've got to realize that you've always got to be vigilant and make sure that they're safe and the kids are safe. So, implications for future research, where we're headed at the University of Arkansas. We really are still focusing on looking at the human-animal interaction among all these groups, and also seeing if having pets at home make a difference in the success or not success of animal-assisted therapy. It's very important in the field of autism to look at each one of these groups to see exactly how a canine can be trained to achieve the goals that we want to achieve. We're also wanting to look at the role of oxytocin and cortisol. So typically children with autism have lower oxytocin levels. And oxytocin is the love hormone. It's the pro-social hormone. There are even nasal sprays that are marketed. I'm not endorsing them to increase a child's oxytocin level because we suspect that it's low in children with autism. But we know from recent research that children who interact with dogs have an increased oxytocin level within 60 seconds. And so that's one of the reasons Griffin's trained to provide deep pressure therapy, like a hug, because that causes the brain to release oxytocin and it calms the child down. And my theory is that this is why animal-assisted therapy works. Griffin can detect cortisol. He can detect when the cortisol level's going up. And when he hugs a child, that causes their brain to release oxytocin, which then lowers the cortisol level. So hopefully we'll be able to start doing those studies as well. We definitely want to keep looking into the ethical treatment of these canines. And my ultimate goal is to develop a program that can be used by speech-language therapists, by occupational therapists, by physical therapists, by school counselors, anyone who wants to use a dog in their therapy to attain these goals. I want to be able to design a program that we can train you how to do it, and you do it, and you can get similar outcomes as to what we're getting. So lessons learned. This is a picture of when we adopted him. And every time I see it, I think, boy, those paws are so big because I've never had a dog the size of Griffin before. Our dogs have always been much smaller. But if I could tell myself 2 years ago, all right, Michele, you've got this dog, what are you going to do? Because it doesn't look like it, but I was terrified in that picture. I would tell myself, number one, yes, canines can be used for much more than just providing comfort measures. We can use these canines to achieve our therapy outcomes, that they provide a sense of security in the therapeutic setting, that children are motivated to attend sessions. We have very few no-shows in our animal-assisted therapy program. And if you work with families in Northwest Arkansas and you have very few no-shows, you're pretty impressed. We have really good attendance because the kids want to come back. They are motivated to attend sessions. They're also motivated to do the tasks that we work on in our table time because they want to earn more time with Griffin. And then I would tell myself that yes, canines can enhance the therapeutic effect and help these kids attain their desired outcomes. So I would like to thank you again for coming to the presentation. I would like to thank you for coming to all of the symposium today. Invite you to stay for our keynote speaker tonight at 6 o'clock, Dr. Temple Grandin, who I'm very excited to have. I also have Danielle and I's information on the screen, as well as our website, and Griffin has his own Instagram. He's, extra. So it's at Dr. Padfoot. And again, thank you so much for coming to my presentation today. I'm done. Dr. Casita just told me I needed to ask if anyone has questions, so I'm going to do that.
Is there any research on how long the oxytocin levels stay up?
No, but I really want to do that, and I've designed it. I just need the money for it. No, there's no research, but what I've noticed with looking at the kids' scores is that their emotional regulation and their prosocial behavior is consistently increasing each week. And so that makes me think that their oxytocin level is going up each week and staying up. And that's why they're coming in more regulated. Great question. Anyone else? Oh, yeah. So Griffin's legal name is Dr. Griffin Padfoot. He is named after the character Sirius Black in Harry Potter, because Sirius Black is a wizard who turns himself into a black dog named Padfoot. And my husband right there would not allow me to name him Padfoot. And so I named him Griffin because Sirius Black is from Gryffindor. And the reason it was important to me, I'm glad you brought that up, a lot of kids love Harry Potter. And a lot of the kids with autism, you may notice, have great imagination of their creative and fantasy world. They like to make their own stories. They like to draw pictures of these creatures that they developed. And I thought I can use that to get them to talk to me. And I found it was so effective that when I went through all of the study that we did the year before, I thought I'm going to completely change the clinic. And now we have Harry Potter house banners. A part of EMDR therapy is the children choose a future template, a desired behavior they want to attain. And so, for example, I have one child who's enrolled who is dyslexic. And he chose Ravenclaw because that's the academic house. And he wants to see himself academically successful. And so I said, you're in Ravenclaw, way to go. We hung up interactive lights that have a wand that I can turn on. And the kids have a little wand. And Griffin knows when the kids have the wand, he's supposed to listen to them. Because you can imagine it's hard for him to know who's talking to him. The caregivers, bless their hearts, they talk to him as much as the kids, and I have to constantly say, he's here for them. But I give the kid the wand, and he knows, oh, I'm just listening to that kid. So I'll have the children who are pre-verbal or who speak in phrase speech point the wand up to the lights, and I'll hold my remote wand, and I'll say, tell that wand, turn on. And they'll take their wand and they'll say, turn on, and then I'll click and it turns on, and they go crazy. They go crazy. So I do include a lot of fantasy. Again, don't underestimate play therapy. It really works with these kids.
So how many people or team members did you have when you were training for the last couple of years?
I worked with 4 trainers because not one person could do all of that. And so we started with therapy dog training first. And then I had 2 therapy dog trainers. And then I had an ASD service dog trainer who also works with the University of UMKC in Kansas City. And then I had my last trainer, he is out of Grove, Oklahoma, and he finished Griffin's ASD service dog training.
How can we make more Griffin more accessible?
That's a great question, and it is something on my mind. Is Griffin just a great dog who can do these great things, or can we train more Griffins? So that's why I'm looking at the canine behavior in the studies. What's the temperament that we need to do this kind of work? Dr. Scott's Bella, I get so jealous. I'm being honest. I get so jealous. She's a golden retriever. That dog can sit and not wiggle and be petted, and she's wonderful. He sees red scrubs and he runs to them and wiggles, and he's excited and he wants to interact with them. But that's what I need in the clinic. So I think that there are some canines who are suited for it and some who aren't, and I need to study that further and see what temperament would be best. Nico.
So your study included like oxytocin levels and cortisol levels. Does your study also account for the vasopressin, dopamine, and serotonin levels in autism?
Can you repeat that?
Yes, so my friend Nico, who's very smart, asked me, I'm accounting for oxytocin and cortisol levels. I would like to look into that. But what about dopamine levels and norepinephrine levels and other neurotransmitter levels? And that's an excellent point, Nico, excellent. The problem with that for me and where I'm at is I can measure oxytocin and cortisol pretty easily in saliva, and it's pretty it's sufficient, and it is consistently accurate. Dopamine would require a stick, and I really don't want to do that yet. So, but that is something that I should keep in mind for later. Absolutely. Anyone else? One more, my director says. Yes, ma'am.
Would you consider taking candidates to try to train to be something like a Griffin or a prototype Griffin?
I really do hope to expand our services of our clinic because I do see how he's done, and I have great hope that we can train many many handlers to be able to do what he can do. So it's always on my heart and mind to be able to do that. Absolutely. Well, thank you guys so much. Thank you for your patience with him. Have a great night.